Everyone. Uh, we'll be talking about OCTA Discourse. OCTA is a non-invasive, rapidly evolving technology that has shown to be valuable in the diagnosis and follow-up of various ophthalmic pathologies. It is still not considered a must-have, but with the current knowledge and that we have, but with newer findings, things remain elusive in the future. So this instruction course will dwell into the basics and we'll try to pick up some diagnostic clues in various ocular pathologies. So first I invite Dr. Asha Purna Burgoyne. She's a vitreoretinal consultant at Chaitanya Institute, Palarivattam. She'll be telling about the basics of OCTA. So over to you, Dr. Asha.
Thank you. So OCT angiography is a non-invasive imaging modality, which is basically an extension of the OCT and which visualizes perfused retinal and choroidal vasculature by using motion contrast in a depth resolved fashion. Although OCTA is not considered superior to FFA ICZA, but it has certain advantage over FFA. Like it does not use dye, so dye-related complications are avoided, and patients who are contraindicated for FFA ICZA can undergo OCTA. As it does not show any leak, pooling, staining, so vascular details are better delineated, and it eliminates the narrow transit time of dye coming in and flushing out with FFA and ICZA. It can image the retinal capillary plexus at different levels. No other modality can do. And it also helps in quantification of certain parameters. So coming to the principle, like OCT, it acquires multiple A scans which combine to form B scans. And when these B scans are repeated at the same location at a short succession, temporal changes from moving objects can be picked up. And this multiple adjacent B scans over extended regions can be used to form a 3D retinal structure, and we can visualize blood flow. So this brings to an important concept called the decorrelation signal. This is basically the subtracted signal caused by blood flow, and it is due to difference of signals due to the moving particles as compared to the static tissue. So the interscan time is the time between T1 and T2. And the importance of this interscan time is that if we use a longer interscan time, it gives a better chance to pick up slow-moving vasculatures like the polyps and microaneurysms. And vice versa is also true for short interscan time. But most of the machines, they have a preset interscan time to minimize artifacts and display flow. The commercially available machines uses various OCTA algorithms. The importance is that when we read a report, when we read an OCTA report, it can lead to different diagnostic interpretation if we see from different machines. The 4 distinct capillary plexuses which we can see in OCTA are the nerve fiber layer plexus and superficial vascular plexus, which is seen in superficial vascular complex, and the intermediate and deep capillary plexus, which together form the deep vascular complex. When we get images from an OCTA, the raw data from OCTA, we can see it as an en-face image or section images. The en-face image can be of 2 types. It is the structural en-face image, and we get the OCTA image. When we interpret an OCTA, the first thing which we should see is whether the right area is imaged or not, whether the pathology or the area of interest is imaged. Then we look at the en-face image. Any abnormality which we can pick up any abnormality in the OCTA image, but we should make sure whether it is a real image or real pathology, or is it some projection artifact or any other artifact. So we look at the segmentation lines, whether it is segmented at the right place. Once we know that it is segmented well, then we look at the flow overlay, whether it is corresponding, whether the pathology is corresponding to some flow there. This is the normal appearance of superficial vascular plexus and the deep vascular plexus. These 2 vascular plexuses are most commonly involved in retinal vascular diseases. In fact, OCTA is the only modality which can visualize the deep capillary plexus, which is the first to be affected in many vascular disorders. So abnormalities in these two slabs can be seen as either abnormal presence of flow like the NVEs, or abnormal absence of flow like capillary void areas, and abnormality in vessel symmetry, like we can see these microaneurysms. The avascular zone and choriocapillary slab usually does not show any vascular channels. Anything there is pathological. These two layers, these two slabs helps us to pick choroidal neovascular membranes. Little bit about OCTA analytics. OCTA helps us also give some numerical measurements which helps to objectively assess disease severity, progression, also helps in documentation and follow-up of a disease. Like the vessel density, vessel length density, fractal dimension, and we can measure the area of foveal avascular zone. Coming to artifacts, these are the unwanted extra findings or missing findings, which is seen in any imaging modality but is more prevalent in OCTA. And it can challenge correct interpretation and reproducibility. So why do we see these artifacts? It can start from the very beginning, like when we acquire the image itself, it can like defocus artifact and decentration artifacts, or due to some bulk motion like eye motion, head motions of the patient, or some intrinsic property of the eye or image processing or during display strategies. So this is the most common artifact which we see in OCTA, the projection artifact. It is the replication of superficial layers in the deeper layers. But due to the advanced technologies, the advanced softwares, this projection artifacts can be removed, and we can get only the abnormal, only the pathological appearance. So another artifact is the motion artifacts, which can be due to bulk movements of the eyes, head and neck. It is seen as a section in the en-face image, and corresponding flow signals will be very dense. Different types of motion artifacts are double lines like crisscross patterns or blink artifact, where a complete area in the en-face image will be missing. When there is obstruction to the flow, to the passage of light, there can be appearance of flow void areas in the deeper layers. When the beam hits some obstruction like vitreous floaters or vitreous or any other opacities or even drusen. So how to be aware of that? So when we see any hypodense area in the OCTA in the en-face slab, we should always see in the structural OCT slab. If in the structural OCT slab the same hypointense area is there, that suggests that the beam was obstructed and it is not a real hypodense area. So this OCTA algorithms, they automatically segment slabs with definite retinal boundaries, and the vessels within that are projected as en-face image. But these were developed using healthy eyes with defined retinal layers. And segmentation failures can be seen if these retinal layers are altered, like in ERM, edema, ischemic retina, or PED. But we can correct it by two ways, either by slab selection or by manual segmentation. So this is a small video. This is how we segment. These are already selected slabs. We can either click in the slabs like the superficial vascular complex, the deep vascular complex, or we can manually retrace the boundaries like in this. We have to go to the choriocapillary slab, and then we can select a specific width, and then we can trace it. Here we can see that when the slab is placed properly, we can see the network. But if it is scrolled downwards or upward, we might not see the network. So indications of OCTA, it has been a valuable tool in wide range of ocular pathologies, most commonly used in diabetic retinopathy, AMD and PCV, which will be dealt in the subsequent talks. It can also be used in retinal inflammatory disorders for diagnosis as well as follow-up. In hereditary disease, mostly in BEST to pick up the CNVMs. In retinal tumors to differentiate choroidal nevas from choroidal melanomas. In retinal capillary hemangioblastomas. So coming to an end, OCTA has become a important tool in retinal vascular imaging. However, we should be aware about the different artifacts, and we will get meaningful data from OCTA only if we know about the artifacts and we have some proper training. Thank you.
Excellent coverage of the basics by Dr. Asha. Next, when we talk about OCTA, it's always, there's a preconceived notion that it's only something a retina specialist has to deal with. So we wanted to know what is the, use of OCTA in glaucoma. So I invite Dr. Kiran Gopalakrishnan, who will dwell into this topic. Over to you, sir.
Thank you, Rahul. So, OCTA in glaucoma. So, in glaucoma, there had been numerous studies and an emphasis on the optic nerve head blood flow and its correlation to glaucoma progression. But all these studies basically looked at the large blood vessels through color Doppler imaging. With OCTA, you could now image the microvasculature. So, this was the first paper on OCTA in glaucoma in 2015. So a couple of months back, I type in OCT angiography in glaucoma in PubMed and I find 814 results on publications. And you can see the number of publications on OCTA in glaucoma peaking almost, I think in 2022 or so. So there are various OCTA platforms. The AngioView is the most widely published platform, studies in glaucoma, followed by the Angioplex, that is the Cyrus version. The one I have access to is the angiography module on Spectralis. So what are the three scan areas that we use for glaucoma specifically? So they are exactly mirroring the scans of structural OCT, the peripapillary scans, the ONH scans and the macular scans, just like your structural OCT scans. And the three slabs which we generally use for glaucoma, the superficial slabs which looks at the ILM to IPL where all the major changes in glaucoma happen, the deep layer up to the OPL, and finally the choroid slab. So which area or slab is more valuable in glaucoma? So this is a systematic review and you find that the peripapillary region had the highest discriminative abilities. That's the area that is more helpful in glaucoma compared to the other two. And among the two, superficial and deep slabs, if you understand the OROC values, you will find that the superficial slabs have the higher discriminative ability compared to the deep slabs, especially in the superior and inferior regions, which makes perfect sense in glaucoma. A quick example, an inferotemporal notch. You can see the loss of microvasculature in the inferior areas on both the peripapillary scans and the macular scans. You can see that it is more prominent in the peripapillary scan. Similarly, in the peripapillary, if you look at both the superficial and deep slabs, there is loss in both areas, but again more pronounced in the superficial slabs. So what are the OCTA parameters that are used in glaucoma? Because of multiple platforms, there are so many parameters. The most widely used parameters in glaucoma is one is the vessel density. The term itself is self-explanatory, and the other is flow index, which looks at the area of perfuse vasculature, and therefore it is described in units of 0 to 1. The higher value implies a higher flow index. The first question is, can OCTA distinguish glaucoma from healthy subjects? The answer is yes, it can do so very reliably. This is a meta-analysis that looks at all these studies, and if you understand forest plots, you see that all the studies show that glaucoma patients have a lower vessel density than healthy subjects. And the other question is, can OCTA correlate well with a well-validated test for glaucoma like your structural OCT? And the answer is again, yes, it can correlate well. This is an OTA, ophthalmic technology assessment from the American Academy. You find that there is a moderate correlation between vessel density and RNFL thickness. If you look at the R and the R square values there. And the important thing is, does OCTA correlate well with the gold standard in glaucoma, which is visual fields? Again, the answer is yes. If you look at correlation values, there is a moderate to strong correlation between vessel density and the mean defect or mean deviation which you get from your perimeter. So this is slightly stronger correlation than we want with even structural OCT. A quick example you find if you go from the healthy to the severe glaucoma from the left to the right, as the scotoma is increasing in your perimetry, there is a corresponding increase in loss of vasculature in the OCTA as well. So at this point, OCTA and OCT and visual fields, these are complementary. The question is OCTA superior to OCT? Can it give you some information earlier than your structural OCT? This is not really established at all, and that is why I put a couple of question marks there. So this study actually looked at the comparison between OCTA and OCT. So all the studies I have marked with orange, these are all studies which show that OCT is, your traditional OCT is superior to OCTA in glaucoma, and only a couple of studies show a contradictory result where OCTA was superior. A quick example, you can see an inferotemporal hemorrhage there. The field is more or less normal, so this is a pre-perimetric glaucoma. The RNFL deviation map is easily picking up the loss of RNFL there in the inferotemporal region, but the OCTA is not picking up anything there. On the other hand, if you have a contradictory result, this is a study on glaucoma suspects and looking at the inter-eye asymmetry. The fields are normal. If If you look at the total RNFL thickness on structural OCT in both eyes, both are showing the same values. But there is an asymmetry if you look at the OCTA data on the left eye, which is showing about a 2.5% decrease in vessel density. But it is just showing that there is an asymmetry. Only if we prospectively follow these patients up will we know if these patients subsequently go on to develop glaucoma. Unless that is established, this is not of much use at this point in time. Now, obviously, normal tension glaucoma is one area where a vascular pathology is thought of, and therefore we think, okay, is OCTA superior to OCT in normal tension glaucoma? Again, the results are not very consistent. You will get both results. So this study shows that the dotted lines there, that is the neuroretinal rim values derived from the structural OCT. You find that it has higher sensitivity and specificity at lower treatment IOPs. Now, on the other hand, I can give you a contradictory result again here. The HTG is high tension glaucoma, NTG on the right hand side. You can see that all the values there of vessel density is lower compared to the high tension glaucoma, in spite of both these groups having the same RNFL thickness on structural OCT. So you will get contradictory results on different publications. What are the various challenges we have with OCTA in glaucoma? One is the lower repeatability and reproducibility with compared to OCT. OCTA takes more time to acquire images and you have greater chance of artifacts, and therefore this study which looked at the intra-visit variability itself, you can see the higher bars with the OCTA compared to OCT showing a higher intra-visit variability. Inter-visit variability is also much higher with the current OCTA platforms compared to OCT. That might explain some of the reasons why you get contradictory results. And the other thing is the lack of quantification in many platforms. For example, the OCTA which I use, the Spectralis has no quantification data for glaucoma. You can see that there is a loss of microvasculature in the peripapillary scans, inferior and in both the scans, but there is no quantification data. And even in platforms where there is quantification data, there is no normative database. So in example here, you will find that you have the normal eyes and therefore you have the data there, but there is no distribution of normals, unlike the structural OCT, which will show you a color-coded Tisnit graph and even the Gave heat sectors based on distribution of normals. So the question is, should I perform OCTA routinely in glaucoma and glaucoma suspects? Well, OCTA can only complement your structural OCT and your fields in glaucoma with whatever we have currently. And there is clearly no evidence of OCTA superiority in preperimetric glaucoma or in normal tension glaucoma over structural OCT findings. And therefore, it's certainly something that can be useful only for clinical research at this point of time. Thank you for your kind attention.
Thank you, sir. An excellent talk. Now, next I invite Dr. Shishir. He'll be talking about OCT and CNVM.
Thank you, Dr. Rahul, for having me over, and thank you, KSOS, for this opportunity. So I'll be talking on decoding the matrix, OCT angiography in CNV, basically how it can help in your practice. So OCTA in CNV is important. First, you can even establish a diagnosis, also know the phenotype and morphology of the type of CNV, and it also helps you in management, basically to follow up on how the anti-VEGF is acting, that is the treatment, and you can also get to know the natural history. Also, if you are doing research, planning to publish an OCTA, any paper is incomplete without an OCT angiography. So OCTA in CNV has been described in wet AMD and also non-AMD CNV. So the wet AMD is 3 types, 1, 2 and 3, and there are different types of CNV which can happen with myopia, posterior uveitis, could be an idiopathic CNV or even with retinal dystrophies. So coming to OCTA in wet AMD, there are different structures and types of patterns of the vasculature which has been described. So if you based on the shape, it has been described as tortuous or C-fan shape or lacy wheel, and based on the pattern or branching pattern, it can be divided into tiny capillaries, and even on anastomosis, how the vessels are anastomosing with each other, whether there are any loops or there are no loops, and also based on the morphology. Some of them, they have a what you call as a sentinel vessel, and also you can also have, when you have atrophy in AMD, you can also have a perilesional halo where the lower part of the choroid or the choriocapillae is visible more on the OCT angiography. So I'll be delving into some few cases and to show you how you can use OCT angiography practically in your practice and how important it can be. So let's talk about this case 1, 60-year-old male, mild disturbance in vision, left eye 6 parts vision. Fundus exam shows something there just below the fovea. He's got grade 1 cataract and diabetic, and he's also a diabetic. Now when you look at this, do the OCT scan there, fovea is fine, but then just below the fovea you can see this shallow RP irregular elevation there. So there is no fluid, there is no subretinal hemorrhage, it's just this elevation what you can see on the scan there. And then when you do the OCTA, you can see this hyperreflective vascular network seen at the area of the RP fit, where there should be no vasculature at all. And so we know that this is a subclinical CNV, and this patient requires close follow-up and monitoring for exudation. And if the other eye has CNV, then 10% of the fellow eyes you can progress to wet AMD if you don't follow, you have to warn the patient and follow them up very closely. So let's look at another case. 64 male, decreased vision, left eye 6/18 is the vision, pseudophakia, both eyes with vitreous loss, and dry AMD is seen in the right eye. And on the left eye, when you see, there are also soft drusen present, and then on the OCT you see this small hyperreflective membrane which is above the RPE, and there is subretinal fluid just above that. And when you do the OCTA, you can see this nice beautiful C-fan shaped vascular network at the RP fit, and also at the level of the choriocapillaris. So here and then this is post-treatment. Earlier the fluid was there, and after one injection of Eylea, you can see that the fluid has resolved. However, that small membrane is still there. And when you do the OCTA, this is post-treatment, you can see that the network has regressed, and the distance between the vessels has also increased. So the fractal dimensions has increased. So this is a type 2 CNV or an MNV, and OCT is a good non-invasive tool for monitoring disease progression or treatment response in CNVs. So we also face these situations in our practice. So this is, we don't know, CSC or CNV, because some of these CSCs, they're present with this, this shallow RP elevation or these irregular, flat PEDs which we see. And so that's an example. 55-year-old male, decreased vision right eye, 6/24, no systemic illnesses, and then this is the OCT. We don't know whether it's CSC or it's a CNV. That's what the OCT is showing, a small shallow RP elevation there. But when you do the OCTA, you get this nice small vascular network which you see there. And so we know that this is a CNV. So if you want to differentiate CSC, CNV, OCTA can be of help, especially when you have the small shallow RP elevations. So OCTA is helpful in ruling out a CNV, as the management is different for both. CNV will require injections. For CSC, the treatment will be either a observation or a PDT. So coming to another case, 68-year-old female, decreased vision left eye, no systemic illnesses. When you look at the fundus photo, you have this small intraretinal hemorrhage there, which I have magnified, you can see it. And on the OCT, you get this small intraretinal cyst there with hyperreflective material just below that. And we do the FFA and the ICG, and then we see that this vessel is actually dipping deep and going into and connecting into the choroidal vessel there on the ICGA. So this is the early frames, and then once you go to the late phase, there is leakage also there, pinpoint, and then there's a fuzzy hyperfluorescence, and you can also see this vessel connecting deep into the choroidal vasculature there. So when you do the OCT, you get this nice network at the layer of the RP fit, like a Medusa head appearance, and then you can see the vessel, the actual retinal vessel, which is going and dipping into a loop. So you can see this vessel is going and connecting into the choroidal vessel or to the network underneath. So as you go from the retinal plexus down to the choroid. And then when you superimpose onto your angiography image, you get this again, the same vessel which is dipping down. So here what we have is a type 3 CNV or a RAP lesion. And the advantage of OCTA here is its ability to reveal the vertically oriented components, as you have the vessel which is dipping down into the intraretina and then going on to the choroid. So another case 5, 55 female, decreased vision both eyes, 612 in the right eye, 618 in the left eye. She's dyslipidemic, and you can see this nice glistening reflex all around the fovea, both eyes, and then there is some small atrophic kind of a patch, pigmented patch there with a vessel dipping inside. So this is nothing but MACTEL type 2. We have MACTEL type 2 in the right eye, and you have a MACTEL type 2 in the left eye, along with this small hyperreflective lesion there with an after shadowing. And when you do the angiography, you get the classic features of MACTEL, which is the the hyperfluorescence all around. And then on the angiogram also, you get the small localized hyperfluorescence there. And when you do the OCTA, you get this network there. So this is nothing but MACTEL2 with a choroidal neovascular membrane or a CNV. And since there is no subretinal fluid, you just need to observe. You just don't need to treat or inject any anti-VEGF. So we have also studied the OCT angio on exudative MACTEL, that is without a CNV, and then OCT angiography is really useful in differentiating these two entities, that is MACTEL2 with exudation and MACTEL2 with a CNV. So OCT can facilitate diagnosis. It can also differentiate exudative variant of type 2 MACTEL with a MACTEL2 and a CNV. So another case, 11-year-old boy, decreased vision right eye, 660, noticed during a school eye screening. He has a punched out choroidal lesion there, which is probably a toxo lesion, and then he's got this hyperreflective or a yellowish area there, and along with that subretinal fluid and a subretinal hemorrhage. So this is the OCT of the same. As you can see, subretinal fluid, subretinal hemorrhage, and you have that punched out lesion there. So this is a toxoplasma scar, and adjacent to that toxoplasma scar, he has developed a CNV. And the OCT angio, without any invasive modality, without any FFA, you can see the OCT angio beautifully depicting the network there around the edge of the toxoplasma scar. So pediatric CNVs, 90% of them are type 2 CNVs, and OCT have great benefit for identification and monitoring the treatment response in such cases. So we have published on OCT angiography in pediatric CNVs, and also we have published on CNVs in choroideremia. And just to give you an example, Dr. Asha Purna mentioned about BEST disease. Sometimes on OCT it's difficult to diagnose CNV due to the BEST. But as you can see, there's hyperreflective material underneath the just above the RP there on the OCT, but when you do the angiography, you can see this muddled closed up network there, which is on the OCT angio, and you see a vascularity, which is a CNV secondary to BEST disease. Also in inflammatory conditions, VKH, you can have peripapillary CNV. So this is a peripapillary CNV adjacent to the disc, and this is post-treatment. You can see the regression in the network or the blood vessels. So this is another CNV seen in a choroideremia patient, which was post-treatment. It had crumpled and became like a fibrotic scar there. So OCT is definitely a game changer as it's non-invasive, it's beneficial in imaging CNVs of various pathologies, and it gives you a clearer view of the deep capillary plexus and the choroid. So it may not detect low flow lesions, and segmentation errors and projection artifacts are also negatively impact the OCTA accuracy, but a continuous improvement and updation of the software definitely helps in identifying and treating the pathology better. Thank you.
Excellent, Dr. Shishir. Especially, I really like the image of type 3 CNVM, the OCTA.
Yeah, thank you.
So, next I call upon Dr. Jyoti Prakash Vyas. He's a vitreoretinal consultant at Giridhar Eye Institute. He'll be talking about the applications of OCT in a diabetic eye. So, over to you, Dr. Jyoti.
Thank you, Dr. Rahul, and KSOS for the opportunity. After all these wonderful talks, I'll be talking about applications of OCTA in the diabetic eye. The first question which sprung to my mind when I first heard about OCTA was that whether it's an essential investigative modality or just a gimmick which is there in the market for us to play with. To answer this query, I just looked upon into the recent literature, and I stumbled upon two recent articles. You can see these are published this year itself. One is the role of wide field OCTA in assessing diabetic retinopathy from LVPI, in which they studied about 150 eyes of 82 patients for different factors, which actually found out whether the disease progression could be staged according to the presentation on an OCTA. So first thing which they looked into was the presence of foveal avascular zone size and the deep versus superficial plexus orientation of the lesions. So they found that the correlation of FAZ was there, which increased with the severity from mild to PDR. So the size of the FAZ increased significantly as the disease progressed, and in all the stages of the disease as compared to a normal individual, the FAZ size in the DCP, that's the deep capillary plexus, was consistently larger across all the stages of the disease. Then came the other parameters which have already been explained in the previous talks, was the capillary non-perfusion area. So if you look at the three numbers here, this is in mild NPDR, the area of FAZ was something which was to the tune of 6.7 millimeter square, which increased all the way till 22.8 millimeter square in PDR cases. Another was the quantitative analysis of FAZ and the CNP for mainly for assessment whether the disease is progressing or not. Now, and also they also added in the element of looking at neovascularization as compared to wide field fundus photography. All put together, if I read through it, you will not be surprised. If you look at it, it will be very visually striking. To the left of your screen, you can see this is mild NPDR, and as you progress toward the right, it's a proliferative diabetic retinopathy. The lower part, you can see in this retina, you have a reasonably good foveal avascular zone with a good peripheral perfusion, and similar is seen in the OCTA photograph of the same patient. As the disease progresses, the FAZ tends to become irregular and gradually enlarges. There are dropouts in the capillaries, and you can see also in the wide field angiogram, you can see gradual capillary non-perfusions increasing. Then if you compare it to the fundus photography, this patient was actually, this is from the same article, this clinically was labeled as a moderate NPDR patient, but when a wide field angiogram was done, they actually found out these were hidden neovascular elements in the periphery with massive capillary dropouts, which turned out to be a PDR and was treated accordingly. Then correlation with visual acuity was also assessed, and the patients who actually showed an increase in the foveal avascular zone also had a significant drop in visual acuity as the disease progressed. So implications for clinical practice: do you clinically use OCTA normally in a case of diabetic retinopathy? The answer would be a blank no, because clinically the judgment of diabetic retinopathy is based on your clinical judgment, how you look at the fundus and how the presentation is there. But this adds to your knowledge, and this as a non-invasive tool, it kind of helps you to understand the disease faster, and your intervention can be planned earlier on as compared to waiting for waiting for the lesion to develop completely. Another article which was published last year was again in diabetic retinopathy OCTA assessment. So they found out that since it gives you a 3D visualization of the entire structure, they found out the key metrics which had to be studied in this. There are more of research related articles, these metrics, but yet to kind of utilize into the clinical practice. They include the foveal avascular zone, vessel density, as was previously talked about in the previous talks, and flow analysis along with neurovascular coupling. Now, neurovascular coupling here happens to be an interesting concept here, in which we can actually antedate the appearance of a particular lesion prior to any clinical sign of that. That is, we can predict whether the lesion is going to appear in due course of time or not. So in the foveal avascular zone, they looked at the area, the circularity, and the parafoveal vessel density. If you look at this is a very nice picture from this article. To the left of your screen is a normal foveal avascular zone, and to the right is a diseased one. In the left, they actually divide it into 4 quadrants. and it is called a grade 0 capillary foveal avascular zone with 0 capillary non-perfusion. To the right, 3 quadrants out of the 4 show an irregularity of the margin of the foveal avascular zone, along with variable degrees of capillary non-perfusion in all the 4 quadrants. Vessel density, again, as previously mentioned, blood flow and neurovascular coupling. So neurovascular coupling is mainly altered responses are detectable even before visible diabetic retinopathy changes come in. So this is something which is something to look forward to in the near future, because as of now, our basic understanding of the investigative modality and the availability of these tools is not very rampant. It is only restricted to some institutional and large practices. And the other things which are very useful probably are the identification of ERMAs and neovascularization, which are very well delineated. Coming to the 2 cases per se, which I could find out from our recent patients which we have treated. This patient, if you look at it clinically, looks like moderate to severe NPDR with a circinate maculopathy in both eyes. Naturally, you would go ahead with doing an OCT. You can see a massive amount of cystoid macular edema along with a serous macular detachment. Now, I put in this photo deliberately here because here it highlights the presence of significant macular edema will 100% obscure your OCTA picture. You will not be able to judge anything regarding the macular ischemia or comment on the existence of the same. It's similar in both the eyes. Whereas in another case, which was seen to be right eye was showing proliferative diabetic retinopathy just by the looks of it, and the left eye intuitively probably you will think on the same lines, and the patient also had a creatinine of 4, so he was not subjected to an FFA. We directly went ahead, did an OCT which showed a normal macula. We did an OCTA. Here the vision is reasonably good. If you look back, the patient had a vision of 612 N6, and in the absence of macular edema, even now you can see there's an enlarged and irregular foveal avascular zone in both the eyes, which is a silent mention, which gives you a silent hint as to the disease progression as it is proceeding. So now coming to the first question again, whether it's an essential tool or a gimmick. It's actually the title of another article which is published this year itself, and they found out that although the current applications extend extensively to all applications, the main problems are there are no analytical tools which are stratified, there's no strategy which is fixed across different diseases, and various protocols have to be standardized in order to be used in across different institutions and across different trials. So the take home message would be, although OCTA has all these benefits, but it has to be taken with a pinch of salt, that it is yet about time that we go mature onto this investigation, but we need to update ourselves regularly to use it across different indications and for interpreting it reliably. Thank you.
Thank you, Dr. Jyoti, for your well explained and well imaged talk. Now I call upon Dr. Rahul Menon for OCTA in polypoidal choroidal neovasculopathy. Is ICGA essential for diagnosis of PCV?
So thank you, Dr. Asha. So OCT and PCV, is ICGA absolutely essential for the diagnosis of polypoidal choroidal vasculopathy? So I pondered over it and came up with few questions. So the first question is, how is PCV different from wet AMD? Okay, so we always wonder, why do we want to know whether it's PCV or whether it's wet AMD? First, PCV happens to affect the younger population more often than the wet AMD, which affects the older population. And if you look at the natural progression of the disease, AMD will usually lead to a scarring. So what happens is, depending on the size of the scarring, the patient will develop a central scotoma. Whereas PCV, if left untreated, it most often comes to you with submacular hemorrhage, which will be usually very massive, and the vision loss will be very profound. Also, if you look at the morphology of the blood vessels, CNVMs usually have immature vessels, whereas PCV has a more mature vessels. So what happens is, the anti-VEGF responsiveness is different. So wet AMD will under the, like all the anti-VEGFs under the sky that we have right now in the market, you inject any of them, they will affect. They will have good response. Whereas PCV, if you usually start treating with ranibizumab or probably bevacizumab, you will have a very suboptimal response. So that is the reason why we want to know whether it's a PCV or whether it's a CNVM. Now the second question is, how do we diagnose PCV on OCTA? Now, as we all know, on ICG we typically see the branching vascular network, that is BVN, and the polyps. So the branching vascular network appears as a hyperflow structure. Do we have a marker here? Do we have a marker? So the branching vascular network appears as a hyperflow network in the NFAS image, and the polypoidal lesion will appear as a hypoflow lesion at the edges. So branching vascular networks can be seen in most of the automated segmentation slabs, whereas NFAS on the NFAS image, whereas the polyps is not usually picked up most often. Now in cross section, what happens is the polyps may appear as a patchy flow. So if you look over here in the cross section, this red dots that you see, that is called as flow signals, flow analysis. So under the PED, you can see the flow that shows that there's some amount of flow there. So this is the cross section view, which shows where it shows as a the patchy flow. Now the detection of polyps by OCTA, Takama and group found that with automated segmentation, around 75% of the times you can pick up polyps on OCTA, NFAS image. With Wang and group, when they did manual segmentation, they found that in their study, around 92% of the cases, PCV cases, you could pick up the polyps. Chushuan and group is a Chinese group which found that in the same set of patients, by comparing the automated segment with the manual segment, the identification rate of polyps rose from 62 to 86%. Now, the third question is OCTA and ICG comparable? Now, if you look at this image, you can see the on the ICG, you can see the branching vascular network and the polyp over here. This is the OCT image of the same patient where you can see the SSOCT image where we can see the polyp very clearly here. This is another image where you can see the branching vascular network. You can see the polyp lighting up on ICGA. There's a hypolesion here. Most probably there should be an underlying polyp here. And when you get the OCTA, you can see the polyps over here. So, next question. Now, since we can diagnose PCV on OCTA, we want to know whether we will be overdiagnosing it. So let us look at the differentials. So one of the most common differentials for PCV is an occult CNVM. So if you look at the OCTA cross section, you can see the branching vascular network, which can be a part of, on the NFAS image, which can be a part of just an occult CNVM. So you have to look at the cross section, which is very, very important and which most of the retina specialists don't look into. So when we look at the cross section OCTA, in a type 1 CNVM, you will have a diffuse flow signal here, right? So this is basically with the BVN. So in the PCV, you will have the diffuse signal along with under the PED, you will see this patchy flow. So when you see both of them together, you have to have the suspicion of PCV rather than an occult CNVM. Now, this is one case I'd like to show. So this is a PCV case where you have a PED, thumb-shaped PED, which is very classical of PCV. And you can see the sub-RP lesion here. There's a vessel over here, and you can see subretinal fluid. Don't see much intraretinal fluid, which is another catch sign of on OCT. In PCV, you will see much more of subretinal fluid rather than intraretinal fluid. And in NFAS image, you can see the branching vascular network. You can see a suspicious PCV polyp over here. On ICG, you can see the polyps lighting up, and on the cross-section OCT, you can see the patchy RP signal that I mentioned about. Now, another case, fundus picture shows the typical orange nodule. On the ICG, you can see the branching vascular network nasal over here, and you can see the polyp lighting up. And on OCTA, you can see the branching vascular network with the polyp over here. Now, does OCTA provide any additional information about PCV? Now, when we talk about polyps, okay, we all consider the polypoidal lesions to be aneurysmal dilatation of the neovascular tissue, which is very much similar to the aneurysms that we find in systemic circulation. Now, this belief is on the basis of, on ICJ, we see the phenomenon of dye washout and pulsatile or turbulent blood flow. But surprisingly, on histopathological examination, most of these PCV cases, they did not find a single aneurysmal structure. Now, this study from a Chinese group found that These polypodal lesions are not actually polyps, but tangled vascular structures. You can actually see them as a glomerular type region rather than single aneurysm. So this is something new that we got to know from OCTA. The second, so one more next question would be, can OCTA be better than ICGA? Now, in the Everest study, no, we are talking about Everest study which happened decades back. Now, what happened was the RP window defects were identified as polyp in ICG. That is one of the pitfalls there. Now, if you look at this image, this is the same patient. This is an SS OCTA, not a normal typical traditional OCTA. So if you look over here, you can see the branching vascular network and you can see around 5 polyps lighting up on ICG. But the same patient, when you do an SS OCTA, you can get around 8 polyps. Now, the importance of polyp is based on the treatment, because when you follow up this patient, you cannot do an ICG every follow-up. When you get a follow-up these patients, this polyp reactivation and regression is something which we would like to know to actually counsel the patient regarding the number of injections. So here it outscores ICGA. Now, what are the pitfalls of OCT and diagnosing PCV? Now, what happens is when there's reduced blood flow in polyps, there's reduced detection of the on OCTA. Also, many times this PCV will not be normal this thing. They might have a large PEDs, so getting a good segmentation slabs is difficult. They might sometimes present with submacular hemorrhage, or they might be in an extramacular location. So getting an OCT in such cases are a little difficult. Now, also what happens is after treatment, now when a treatment now case comes to you, it is easier to pick up these findings. But many times in the clinics, you might see a patient who has been treated as probably diagnosed with CNVM somewhere else and treated with probably few other injections elsewhere. Now, what happens is after treatment, there's a phenomenon called hyalinization. So or thrombus formation. So what happens is this branching vascular network and the vessels over here, they get hyalinized. So the blood flow goes, even reduces up further. So then to pick up such cases on OCTA becomes a little challenging. So are we at a stage where we can say, like, we can throw away our ICG machines and solely depend on OCTA? No, we are not. But it does help us our cause. So this is like a small flow chart which we can when we approach a case of PCV. So you see cases of suspected PCV, get an OCTA done rather than subjecting them to a invasive ICGA. You look at the OCTA, you can see the branching vascular networks with polyps. You can treat it as PCV. You don't need to subject them for an ICGA. But if you don't see a polyps, you have to get an ICGA, and dependingly you can classify it as BCV or occult CNVM. Now, suppose in the branch OCT itself, in the initial image itself, because of hemorrhagic PEDs or extramacular location, whatever reason, you're not able to pick up, get a good image, directly subject them for ICG. Thank you.
Thank you, Dr. Rahul, for a crisp and inclusive talk. So we have come to the end of our OCTA discourse.
So first of all, I would like to ask Kiran sir one question. Kiran sir, like most of this, the OCT and glaucoma, optic nerve head that we're talking about, they were about, I know you have done your part of research. I wanted to know, does, most of these glaucoma patients, they have the diurnal fluctuations much more. So do you think there is a chance that probably because at a certain IOP, probably the OCT parameters that we get might be different in these patients?
On a given patient in different times of the day, you mean?
Yeah, different times because depending on the pressures.
Even if it is so, how does it help us actually? You see, first of all, we are not even doing diurnal IOPs now. First of all, when during my residency, I think Matthew was also here. So we used to measure our diurnal pressures. This is prior to 2010. I don't know what is this current status now. We used to measure IOPs at 7, 10, at about 3-hour intervals up to 10 o'clock only. We never used to take the pressures at night. So diurnal variation in pressure itself is not being recorded, but it is possible that at slightly higher pressures there might be some difference. But the fact of the matter is, even in ocular hypertensives, so ocular hypertensives haven't had any damage to the optic nerve as such, right? There is no evidence at this point to suggest that the OCTA values are actually lesser, their vessel density compared to controls.
Only when there is actual damage either picked up on structural OCT or when you pick it up on perimetry, do you get anything, similar in OCTA as well. So the rise in pressure itself is probably not going to make much of a difference. The point I was trying to make is that OCTA gives you very clear information regarding loss of vessel density in glaucoma. But it is only showing you whatever changes are being shown in your structural OCTs, nothing showing beyond that. Is it able to pick up a change prior to a structural OCT change? That is not happening regularly. So that is why its use is very limited at this point of time. In fact, one of the studies which I showed, when you compare structural OCT and OCTA, almost every study is showing a better the OROC values, the area under receiver operating curve. You study those OROC values. Almost every study is showing that the OROC values with OCTA is actually less than the OROC values with structural OCT. Therefore, its use is very much limited to clinical research. In fact, another point I was talking about the publication, right? The peak of publications is actually, it's coming down now. From 2023, the number of publications are coming down. So maybe people are, losing interest in glaucoma.
Next, I would like to ask Dr. Shishir, are you doing traditional angiography like FFA ICG for all your CNVM patients treatment now, or are you are you in a position where you can actually get an OCT and then start the treatment?
No, actually, I'm not doing FFA ICG for everybody unless if I suspect PCV on the OCT. If it's wet AMD, OCT angio is good enough, especially if it's type 1. Or even if I suspect a type 3, then I would get an FFA ICG done. But at baseline, all of them do get an OCT angiography.
And Dr. Asha, I just had one question. On the OCT, right, we know we have traditional angiography has its own space, but is there any space, any ocular pathology where you would say a kind of OCT outscores traditional angiography?
In CSCR, to follow up a case of CSCR, and if we see in the OCT, if we see hypo DLS or like hyper DLS, I think it would be better to do an OCTA compared to ICG. And also in a case of foveal neovascularization, like sometimes we might miss that foveal neovascularization due to extensive leak. So in that case, I think OCTA would pick it up very well.
Because of the unhealthy RP, you mean to say?
No. In a case of foveal neovascularization, like in PDR,
Okay.
it might look just as a speck of hemorrhage in the fundus photo, or in FFA it will just show leak. But if we do an OCTA, because of lack of leak, we will see the neovascularization quite well. So I think it has an edge in PDR.
Yeah, one possible advantage, because of the time issue I did not discuss, was one possible advantage of OCTA could be actually, in fact, in advanced glaucomas. We always try to pick up the early glaucomas with OCTA. The reason being that your structural OCT has a floor effect that happens quite early, like at around 50 microns or so in most of the platforms. Everything will appear red now, and the values may have reached the floor. Whereas there are some indications that the OCTA vessel density has a much lower floor. So let's say somebody has an advanced glaucoma, everything is appear red on OCT, so you cannot use OCT anymore to follow up that patient, where the OCTA can probably be used to further document loss of vessel density, though we would still probably use a 10-2 or a macular fields to be more precise in such follow-ups. But in difficult patients, this could be a potential advantage.
That is an excellent point, sir. Good forward. Anything else? Any questions from the audience? We have to take one.
One question for Dr. Rahul. In a patient, accidentally we pick up some finding, and patient is asymptomatic, and we do an OCT, and we see that there is a DLS, double layer sign, and we do an OCTA for that patient, and there is a membrane, but the patient is asymptomatic. So would you like to treat that patient? Vision is 6/6.
No, definitely no, because even I think Shishir had showed him one case where there's a non-exudative CNVM. So non-exudative CNVM, unless there's most of the studies have shown that unless there is exudation, there's no role for anti-VEGF to be given there. You see a non-exudative, you keep close watch in them, because over a period of 24 months, most of them will convert into exudation, but not necessarily. I have few patients of mine where I've been following for the last 3 years, 4 years, still no exudation. But you see just a non-exudative CNVM with a double S, and you don't have to treat them unless there's exudation. Thank you, everyone.